everyone. Thank you so much for joining us here today. My name is Rebecca Torrence. I'm a correspondent at Business Insider, where I lead our coverage of healthcare startups and venture capital. And I'm very excited to be here today in this conversation about rural health equity and innovation. I'm joined by Amar Kendale, the co-founder and president of Homeward, a healthcare startup that provides care to rural communities in Michigan and Minnesota, in person and virtual. And Candace Richardson, a principal at General Catalyst and an investor in Homeward. I want us to start by setting the stage a bit here. So conversations about health equity have picked up significantly in the past 4 years since the pandemic highlighted some significant disparities in care quality and access to care. And it's been 2.5 years roughly since Homeward launched. I'd love to start with you, Amar. In the time since then, what sort of progress have you seen?
So when it comes to rural healthcare, broadly speaking, unfortunately, there's a lot of headwinds. And we're seeing this in the headlines. We hear about hospital closures. There's 700 hospitals that are slated to close over the course of the next several years. So there's a pretty precarious state of the state when it comes to rural healthcare. Underlying that or consistent with that, you have about half as many primary care doctors as you have in urban and suburban areas. You have about 1/8 as many specialists. So this is the landscape we're talking about. This is really the nature of what's setting up the problem. And ultimately what it means is poorer healthcare outcomes. So rural Americans are experiencing roughly 23% higher mortality than their urban and suburban counterparts for no other reason than where they live. So it's sort of in our own midst, we're seeing a massive health disparity. And it's a community that's generally speaking been underserved perennially. So that's really what Homeward has decided to focus on in order to start to tackle those underlying issues. And our early experience is indicating that there's demand, real demand from payers and from providers and from patients to see something that's a different way to solve these kinds of issues.
Candace, as an investor in the space, obviously there's a ton of opportunity here, a lot of untapped areas of the market, but there's also a lot of challenges, right? Like lower reimbursement rates with more patients on Medicaid, tighter margins for a lot of these organizations, et cetera. How do you think about investing in and supporting technologies that are tailored to the needs of these populations and that really center health equity in these conversations, but that are also compatible with venture capital model and those expectations?
Yeah, it's a great question. At General Catalyst, health equity is really core to how we think about investing in healthcare. It really is integrated into every component of the healthcare models that we're investing in. And when you think about how massive the market is, this is an over $4 trillion market. And when you hone in on where there is very high spend and really poor outcomes, it's very closely correlated to where there's inequities. And so, it's very important every time we're meeting with founders that it's top of mind for them. We think about it in terms of data. So working closely with companies to make sure they're tracking the outcomes that they have. So it's great if you're driving good outcomes on an aggregate level, but how do outcomes look for men versus women? How do outcomes look for different socioeconomic, statuses of people that you're seeing, different geographies? And I think what's really exciting is that from a reimbursement and policy standpoint, there's more focus on health equity as well. We're seeing that in Medicare Advantage, for instance. Health equity will be a bigger part of star ratings going forward. And so there are the incentives to focus on health equity, not just because it's the right thing to do, it's going to drive better clinical outcomes, but it will drive more margin over time as well. And so that's a perfect combination when we're thinking about where to invest and drive venture-like returns.
On the topic of incentives in delivering this care, serving rural populations means serving patients with statistically the worst health outcomes, higher rates of life-threatening chronic conditions, less access to resources like transportation to the doctor. How should these factors affect the financial incentives that go behind designing care like this? So, we're thinking fee-for-service versus value-based care. How do you think about that?
Yeah, I would honestly have to point to fee-for-service as one of the culprits in why we're experiencing what we are in rural healthcare. And so our approach has been to focus entirely on value-based care models because fundamentally what that does is it creates a degree of freedom for us in the design of care that's appropriate for these communities. So if you imagine a world where fee-for-service really makes the way that people get paid very rigid it starts to promote a set of behaviors that center on the hospital, that center on more complex care for sicker people. And in fact, it doesn't incentivize the opposite end of the spectrum, which is preventive care, often which isn't reimbursed very highly, but is really what these communities need. And so as we've approached this at Homeward with the value-based care model, it's allowed us this degree of freedom to take a much more population health orientation and step back and ask ourselves, what does this population really look like? And where are those areas of need? And the answer, in large part, is preventive care, first and foremost, understanding what kind of disease burden this population is experiencing. And then secondly, assuring that chronic condition management, which is one of the biggest issues that faces rural America, as Rebecca points out, that those needs are being addressed with a model that actually can scale to serve the population. So if you think about the time a primary care doctor has in a typical practice, most of that time is focused on the higher reimbursing, more complex patients and more complex billable visits. But what the population is in need of is things that typically in a fee-for-service model don't get reimbursed very well. So that's really what we found is the opportunity for our focus. We can bring those resources into these communities, do something that the existing doctors aren't doing but wish they could do, and support their mission, and use technology to support our ability to do that. Because the other big factor we have in rural communities is physics. These folks are spread out. There's no way around that fact. So no matter what we hope for in terms of trying to create density, there's some really rural specific solutions we have to come up with that are going to overcome those issues of space and start to bridge those in large part using technology and data to make that possible.
Candace, can you speak a little bit to the opportunity in value-based care in rural health and in health equity broadly?
Yeah, we see a tremendous opportunity. I totally agree with what Amar said, and it's one of the reasons why we are very proud investors in Homeward. But there's a very large market, 60 million people who live in rural America. And as Amar said, care needs to be delivered in a different way. And to deliver care in a different way, you have to change how you pay for that care. So I think it goes hand in hand with value-based care. Another really important component to this is how technology is utilized. And there's technology on the back end that is going to provide leverage to really focus resources on engaging these community members, providing world-class care, driving better health outcomes. But then there's also technology on the front end that they're going to be interacting with on a day-to-day basis as well. And so we're really excited about the opportunity to really leverage innovations in the payment model along with technology and care model to drive better outcomes for the population.
Awesome. Amar, to the, what you just mentioned about these communities being very spread out, when Homeward launched, you had mobile clinics as well that would, drive around and serve patients at different locations. But you've since paused that strategy. Can you speak to that and perhaps a bit as well to the challenges you faced in the market and the pivots you've made as a result?
Sure, yeah. So I think one of the things that we've really come to appreciate is that a local presence is critical, especially in a world where we need to build trust with patients. It's very often the case that there's an appropriate skepticism for healthcare providers, the healthcare community, for new brands entering a given area. And a big way to bridge that is to hire locally and to invest in communities so that we're understanding their needs, which are in many ways local. One of our initial experiments along these lines was to take mobile clinics and staff them with our local staff, arm them with technology, but deliver fundamentally mostly primary care. One of the things we came to appreciate, though, as I mentioned earlier, is it's not so much direct primary care that's the missing link in the way that it's typically practiced in a rural healthcare clinic. It's actually a lot of the supplementary aspects of primary care that are missing. So it is that preventive screening, it's the chronic condition management. The other thing that's missing is access to high-cost resources that are very often available in a hospital setting, but not available in community-based clinics because of the cost. And so our model has really evolved to one where we're thinking a bit differently and really evolving to consider what are those high-value resources or procedures that belong in a mobile clinic, where moving that asset around is going to create real leverage and scale. Whereas, this won't surprise a lot of you, the cost of real estate in rural areas is not that high. So opening up a general purpose primary care clinic is not the issue, but making sure that that critical equipment that's scarce is available for people who might otherwise be waiting 6 months or 12 months for a mammogram. Like those are the problems we want to solve using a technology like a mobile clinic.
Yeah, that's fascinating. I want to speak as well to a bit more to the technology piece here, and I'd be curious to hear both of your takes on this. It has been impossible to listen to any sessions at this conference and escape AI, and I wouldn't think usually of rural health equity and AI in the same sentence, but Homeward is actually using AI in some key ways to help with the problems that its patients are facing. Can you speak to that a bit? And Candace, I'm curious to hear as well how you think about making thoughtful healthcare AI investments that make tech-enabled services more attractive and better serve, the populations that the care is being targeted towards.
Yeah, so it's true. There's no avoiding a conversation about AI. I think one of the really interesting things about the way technology more generally shows up in rural areas is that it lags. It doesn't show up as quickly as it does in a lot of our urban and suburban metro areas. Some of the reasons are legitimate. Wired broadband isn't present in the same way that it used to be. But some, I believe, are a real fallacy. And an example is the fact that 5G is now available in rural communities in the same way that it's available in urban communities. So there's been actually a leapfrog phenomenon. We're finding that in many cases it's been more broadly adopted. People with smartphones can access technology and data in a way that they couldn't even just a couple of years ago. So that's a real breakthrough, and I think it opens up a lot of opportunity for the way that we engage with patients. The other thing that's been really interesting in our experience is one of the biggest opportunities is to upskill the labor force. And I think that's one of the first places we'll see AI have a massive impact. We hire local people, as I mentioned, to play roles as navigators. Many of those folks are not at the top of the clinical food chain. They might be medical assistants, they might be community health workers, but we're able to use technology to make them capable of operating at the top of their credential. And that is a real difference maker. In a community where maybe community resources are scarce, if we can make it possible for someone to solve a patient's problem in a day instead of a week, those are really meaningful improvements. And that's a great place to apply technology like AI. Another thing we're finding, in addition to upskilling, is rural communities need a lot of the necessary capacity to be imported from outside the market. So in an urban place, you might have a choice of a specialist to work with. In a rural area, you're probably going to the next closest city. But what if we could actually bring you that clinical resource using technology like telemedicine and make sure that that specialist has all the data that they need in order to understand your health circumstances? Well, now we've got a great use of technology to bridge that gap. It's a very purpose-driven way to apply the technology. It's not just technology for technology's sake, but it solves a problem that shows up very uniquely in these rural areas where we have to bring in capacity that's really not going to be available in that local market.
And from my perspective, I spend most of my time investing in healthcare services companies that are enabled by technology. And I think the transformation happening in AI is going to radically change how these companies scale in a very exciting way. They're going to become less capital intensive, and I think the fixed cost base will change pretty meaningfully. So areas where there's low-hanging fruit in AI, where we're already seeing adoption and a very large impact on how these companies operate, are in areas like AI scribes. We've gotten to the point where the providers are begging for this. They love it. It's changed their quality of life. And we're seeing that pretty much across the board. Other areas like revenue cycle management are ripe for a lot of innovation driven by AI. And I think what's exciting is the administrative burden for services companies is very heavy. And so when you can change the cost structure, even if it's, a few percentage points change to your margin profile, that's more margin that you can spend on engaging community members, delivering the right care. So there's a lot of focus on the administrative layer right now, but we're also thinking about how do you use AI to really transform the workforce and supplement areas where there are shortages. And as you know, there's shortages on the nursing side. There's a lot of specialists with shortages. There's primary care physicians where there's shortages. It's just across the board. So we're very excited about how do you augment, right? Not replace, but how do you augment the existing workforce and really allow providers to do what they were trained to do and what they like to do, which is spend more time with the community's members that they're serving and less time on administrative tasks.
And I'll add just a brief, really interesting observation we've made is a lot of what AI is enabling for us is the long tail of small operations problems that really erode margin. Like in the way you're describing it, Candace, it's the 1,000 administrative tasks that fall on the plate of a care team that AI is going to be really well suited to eliminating as sources of friction and sources of cost. And that lets everybody work at the top of their credential, right? It lets our doctors do mostly just doctoring in the way that scribes are beginning to do that. And I think we'll see that area as the first and probably biggest application in the short term of AI in all these sort of clinical service-oriented environments. It's very exciting.
Yeah, it's a really good point. I think from my perspective, covering this space, seeing the potential of AI to transform a previously less attractive, beyond the ZERP period services business to make those margins look more appealing is very exciting because we need services and we need investors who are willing to back them. I want to spend the last few minutes we have here talking, a bit about what's happened this year in the space. So a lot of major retailers have really pulled back their investments in healthcare this year. Walmart being arguably the most consequential for rural healthcare, since many of its 51 health centers served rural populations. And frankly, I've heard from dozens of investors throughout the year that they're pulling back their investments into care delivery businesses because they see those businesses as too capital intensive. As you mentioned, Candace, many think those margins aren't attractive anymore. What's the silver lining here, if there is one, and how do we move forward despite these major setbacks to continue innovating in rural health?
So I can start. I'd say that we're going through a period of learning, and I think one of the big takeaways is that brand is important, but the brand relationship that consumers have has to be authentic. It has to be consistent with their expectations. And so, while yes, we saw Walmart, a beloved brand, try to enter healthcare and then retract, I think a lot of that has to do with the fact that Walmart is not a healthcare brand. Whereas, if you look at a rural healthcare system, that healthcare system has been in that community for decades. It has a brand for their health. And so what we found is some of the bigger opportunities are actually to create bridges in partnership. So Homeward is young and new, and we're just emerging in these markets, but we're finding a receptivity from health systems to be partners. This has been true in our work that we're doing in Minnesota. We work with one of the largest health plans, Blue Cross of Minnesota, and we work with some of the largest health systems like Centricare and Alamere. And we can approach our patients together. We, Homeward, benefits from the trust that patients already have with these brands, and they benefit from the fact that we're bringing resources and technology and capabilities that they're lacking. So there's a real win-win here, and ultimately the patients win. And we're not asking patients to take a leap of faith in a direction where they just don't know what kind of outcomes to expect, which I think has been a big reason why across the board, retail clinics have sort of failed to cross that chasm of establishing them as not just a trusted brand, but a trusted healthcare brand in the long term.
And you're right. I've seen it as well. There are certain investors who've pulled back from investing in care delivery companies. It is a challenging time, right? We went from a market that was rewarding companies for top line growth to a market that is highly focused on gross margins and path to profitability. And that requires a different way of operating businesses and oftentimes a different team makeup that has that type of expertise. At General Catalyst, we're really focused on investing in companies that really meet at the intersection of financial and societal returns. And so when we think of ourselves as capital providers and capital partners as a part of this broader transformation that we want to see in healthcare, you can't leave out care delivery, right? It's a very big portion of healthcare spend. It's what consumers are interacting with. It's how we pay for healthcare. And so this is a time when we're as active as ever. Luckily, we're structured as a firm to be able to support companies from creation, seed, all the way through pre-IPO and have lots of different kind of flexibility there. So we're really excited and we think there's great returns to be made both societally and financially.
Awesome. That's all the time we have for today, but thank you both so much. This has been a great conversation.